I will be co-chairing this session with Dr. Gabriela Repeto from Chile, and we'll be talking about equity and global access for genomic medicine implementation and the views from different regions. So our first speaker is Dr. Callie Dale. She earned her doctorate from the University of Utah in 2022 and is currently a postdoctoral researcher at the Native Biodata Consortium. She is a citizen of the White Earth Nation of Ojibwe Indians. I hope I pronounced it correctly. And she currently focuses on research on COVID-19 testing and sequencing, spatial transcriptomics, and indigenous data sovereignty. Thank you, Kelly. Thank you for that introduction. I want to start with an introduction in my indigenous language, just to show respect for my ancestors. So, Buju, Kali Indigenous Cause, Bumijime Gogan Dunje Ba Makwa Indodam, Wabanangi Quasis Ni Mama, Da Ni Dada, Christopher Ni Sein, Trey Ni Sheme. I just said hello and where I'm from and who my family is. And that's how we introduce ourselves in our indigenous languages. And today I'm going to be talking about advancing equity and genomics for indigenous peoples. And when I talk about indigenous peoples, I am generalizing to most indigenous peoples, but I will also be specifically focusing on indigenous peoples of North America, specifically the United States. Native American is also a term I'll be using, and that is the political entity of race of indigenous peoples in the United States. I'm at the Native Biodata Consortium, which is a nonprofit biobank and research facility located on a tribal reservation in the United States. We have been talking a lot about there's lack of representation of indigenous peoples in genomics and genomic data sets, and this is present also for indigenous peoples. And I don't need to explain any further that we've been talking about lots of different populations are not represented in these data sets. But there is a really big interest to study indigenous peoples because of their isolated population, because they are isolated populations, and this can lead to complex disease gene identification and understanding hereditary and the such. So, but we have to ask who is benefiting from this research? Are indigenous peoples actually even benefiting from the genomic research being done on our populations? And with this interest plus lack of representation, there is, this has led to unruly collection from bad players. And they don't even need to collect living indigenous people's DNA to understand the DNA that's going on. There's a lot of collection in different ancient DNA artifacts, and they're circumventing tribal sovereignty by collecting these samples and saying that they're not related to a tribal tribal entity that is sovereign today. And it's not just related just to ancient DNA. There are many examples where current or not too far in the past, tribal people have been subjected to research and then abused for other research projects. For example, the most infamous case that I can talk about in the United States is the Havasupai tribe, which are a tribe in the Grand Canyon area of Arizona. This isolated population worked with a researcher at the Arizona State University to research how diabetes is affecting their community. They consented to this research project, but years later, they found out that their samples were being used for other research studies, including studies on schizophrenia, stories or migration stories that were going, or migration studies that were going against their creation stories, and none of this was consented to. And this led to a lawsuit that was settled out of court. And that is really fresh in our minds still, even though that happened at the turn of the century. And that is not just the only thing that's, it's still happening to this day. Genomic research, I believe, is a form of colonization. The genomic researcher by non-Indigenous researchers on Indigenous people is looking for profit of knowledge, profit of money off of what is happening to our people. And the data that is being collected on our people should be given back to our people, and that we should have ownership and collection over it. So the big problem, or one of the big problems, is that non-Indigenous researchers are unfamiliar with how to engage with the community. They're averse to developing these community partnerships. And because these partnerships take time, they may not want to do it because it's not on their timeline, which could also be related to tenure and publication timelines. And people who are getting trained in genomic research are not necessarily getting support on how to have community engagement training. So one of the arising issues around this is that to circumvent tribal sovereignty, they will recruit Indigenous and Native American people in urban settings because they live off reservation. And the majority of Native Americans in the United States do live off reservation, and this places some sort of easier way to collect samples from Native Americans in the United States because tribes only have sovereignty on their reservations or land. And this, most people are forced to live off of the reservation due to the US government, and were subjected to compensation to move to urban settings to make them less native by diluting their blood quantum. But this is a really big issue because and Indigenous data sovereignty should be protected not just on reservations but off reservations. And this sovereignty is the right of Indigenous peoples and nations to govern the collection and ownership and application of their own data. And that is more than just their genetic data about themselves. We're also, the native biodata is also concerned and working on genomic data of our land, of our water, of our resources, and but obviously we're talking about human genetics here. So at the Native Biodata, we are Indigenous scientists working for Indigenous peoples. We're located in the legal and geographical jurisdiction of a tribal nation. And we are first and foremost a biobank. So we are working on keeping samples and data local. The research that's being done on our communities need to be staying with our communities, and they need to be governed by our tribal governments. We're also working on supporting and building capacity for our tribal communities. And we have a state-of-the-art laboratory in what some people call the middle of nowhere, South Dakota. And we're creating this laboratory that is able to do everything that we need to do for genomic research. We are fostering that trust in research again with our community. We are working with elders and youth to create that trust relationship again because of that mistrust. And we're asking our elders to communicate to our youth why it's important that we're doing this. And we're actually doing research that the tribal people want to be done. We're not going in and telling them what needs to be done. We're asking them what they want is done. Many Indigenous scientists have already built the ethical framework for enhancing genomic research with Indigenous communities. There are papers explaining a lot of how to be culturally competent, how to be transparent, and how to disseminate the findings with the genomic research. And the first step is really understanding tribal sovereignty. Each nation has its own type of tribal laws. And some communities do not allow genetic research to be done because of the mistrust in the past. And that's why there needs to be Indigenous researchers from that community doing that work The engagement and collaboration with the community needs to be ongoing and needs to happen before the study starts and after the study is completed. You don't want to be pan-indigenous. Every tribal nation has different aspects of what is cultural and how it's happening, so we can't just go into Arizona and expect the same thing to be happening in Minnesota. And support the capacity that's already happening in that community. And native biodata is a great example of how we are already doing the research for ourselves, and we don't need non-Indigenous researchers coming to our community to do the research. The big principles that researchers need to be following when doing a genomic research or any type of research with communities are fair and care. So fair is very broad with the findable, accessible, interoperable, and reusable data. But Indigenous researchers came up with the care principles about how the data should have a collective benefit for the community. The tribal communities should have authority of control over their data. They have a responsibility for their data, and this data should be ethical. And you can look into how these principles can be applied to other research. One thing that we're doing at the Native Biodata to really advance equity is a dynamic consent portal with our biobank. So this consent portal will be a place for researchers to manage their study with the community, and then the participants will also be able to log into this portal to know what is being produced from their study. A lot of the times, researchers will come in, do the study, and leave and make a profit or get knowledge, or they will, go on with their career, but they won't tell the community what was made out of their data. And so this is a place where participants can know what's going on with the study, and this is also a way to have that this dynamic consent. They can pull the data. They can pull their data or their sample from the study if they see, if something's going, they don't like where it's going. And it really gives this individual consent aspect to it. But before individual consent is even given for a research study, the community needs to give consent to this study. With Indigenous peoples and tribal nations, researchers need to be considerate of how the community as a whole is going to be using this study, and that's why they need collective community consent before the research is being conducted. Another aspect that we're working on is inclusive training of AI and machine learning, and we're making sure that when AI and machine learning is using our data, it's not doing it in a racist or biased way, and we're making sure that our data is being included, but it's being included in the way that we want it to be included and not from this bias standpoint. And a great example is, I had an abstract for a conference. It was too long. I put it into ChatGPT and I said, it needs to be shortened, and it removed the Indigenous authors' names for but it saved the white researchers' names in this abstract. So the bias is already there. We need to be training AI and ML, not just on, research abstracts, but on the genetic data that's going to be happening for our health. So I want to say that we need to be supporting Indigenous researchers. This trust and accountability to improve equity and having this greater diversity inclusion is about supporting the Indigenous researchers that are already here. We're not in low numbers. People are like, oh, I don't know any, but there are so many of us that it shouldn't be hard to find Indigenous researchers. And I really believe it's not about building capacity in Indigenous places. It's about supporting the capacity in Indigenous spaces and building the capacity in non-Indigenous institutions so that when we have to go there to do that education, that we're supported and that we have a place to feel like we're a part of this aspect of research and academia. So I think it's about making everyone else aware of what we are and making everyone else trustworthy so that we can be a part of that research. So, miigwech, and thank you. I'll take questions at the live panel.
Thank you, Callie, for that amazing talk. We'll save questions for the panel discussion, so please remember your questions, write them so that Callie can get some very exciting questions at the end. So our next speaker is Dr. Segun Fatumo. He's an associate professor of genetic epidemiology and bioinformatics at the MRC UBRI, Uganda, and the London School of Hygiene and Tropical Medicine in the UK. He leads the African Computational Genomics Research Group, and his research focuses on the genetic impact of non-communicable diseases in Africa. He also leads different genomic programs in Africa, including the Uganda Genome Resource, the Malawi Genome Resource, and co-leads the Nigerian 100K Genomes Project. Thank you.
Okay. Good morning, everybody. Thank you very much for inviting me to make this presentation. I'm going to be talking about how we need to increase genomic diversity in order to advance genomic medicine in African population. So this is an initiative globally. You see that across the world, there are several initiatives focusing on genomic medicine to accelerate precision medicine. If you look, everybody here probably familiar with the UK Biobank, which has been well characterized. Great database. Yesterday, we heard about the All of Us program in the US, recruiting 1 million people. Australian genomes, Brazil, China, Qatar. You see all over the world, you see biobank. That is how important genomic medicine is. But I'd like to focus on in the middle there, Africa. So you don't see anything coming out from Africa. There's no program, genomic medicine program in Africa. That is very, very serious. So Africa, if you are not aware, Africa is a continent of 1.4 billion people, human beings. That's a lot of people in Africa. Africa is a continent, like I mentioned, with 54 different countries, speaking about 2,000 different languages, 3,000 ethnic groups. Africa is the world's second largest and second most populous continent in the world. What I really want to emphasize is the population in Africa is very, very young. More than 50% of people living in Africa, they are children under the age of 18. In Uganda, where I do most of my work, average age in Uganda is 15.7 years. That is how young people are. Nigeria, very similar, about 16 years average age. I think such population should not be left behind in genomic medicine. By 2050, 40% of the world population will be living in Africa. So African genome is very important, and you've heard colleagues talking about this a lot and show this slide. But what I want to mention here is that we know that there's more genetic diversity in Africa than other populations. What is even more important is that there's larger genetic differences within African population than between Africa and European population or between Africa and Asia population. So in that map, you see a lot of difference between Uganda compared to South African population. So this have several implications. One of them, implication for the modern human evolution. It also means that findings from European population may not be generalizable to African population. It also means that findings within African population, say from Uganda population, may not be transferable to other population in Africa. These are very important. And also, lastly here, it means that there are many, many variants that might be very important that are yet to be discovered. You have seen this slide that Kali just showed now. But what I want to emphasize here is there's no progress being made in terms of diversity in African population. In 2016, the 3% of African genome have been studied. 2019, 3 years the line, you see that decline from 3% to 2%. And last year, in a paper that we published in Nature Medicine, you see now there's only 1.1% of African that have been studied. So we're not making any progress. So the 1.1% of African I mentioned are mostly African American. So if you continue in GWAS catalog and other databases, if you continue to broaden Africans, and including African Americans in the US and Black participants in the UK, we are going to continue to broaden genomic imbalance and also continue to promote, to widen the health disparity, and we will fail to capture the genetic diversity that is needed within African population. So this paper that I published a few months ago, so we emphasize that African Americans' genomes don't capture the diversity in African population. And we give an example of a paper that was published that showed about 5,200 people of North African and also trying to capture them as African. So in that paper, you see more than half of those people in that study originated from one population in West Africa, Nigeria. So there are so many common ancestry, like the Nilo-Sahara-speaking people, Kosan, Otagadara people, that are extremely underrepresented, that needs to be really captured. We need to always remember that Africa is home to some 3,000 ethnic groups, and their genetic diversity needs to be captured. So, like Kali mentioned, Africa is not the only continent that is underrepresented. There's a broad group of underrepresented population, mostly in low middle income country like Africa, South Asian, Latin America, and also indigenous people. So these are very important for genomic medicine. I think that we are doing ourselves harms if genomic study is not diversified to include all population and capture all genetic variants. So we as scientists would like to talk a lot, and people talk a lot about the need for diversity, but we don't actually practice that. I mentioned UK Biobank, which is well characterized. 500,000 people enroll in this program. That 500,000 people include 30,000 that are non-European. So when you look at in the publication, you see that our colleagues, they always exclude non-European ancestry individuals. So this plot shows that 93% of publication excluded non-European population. What is the common reason for doing that? They will tell you that non-European sample, they create noise. Those noise are needed to find genetic variants that are not being discovered. That might be very, very important. So this is also another example of a paper, excellent paper that was published in Nature last year. So many people, more than 600 authors. So what they did in this paper is to aggregate GWAS of about 281 GWASs that make about 5.4 million people all over the world. So height as a trait is one of the simplest traits to measure anywhere all over the world. And you see there's so many GWAS of height in continental Africa, but this paper, you don't see data from continental Africa. So my question is that, so why exclude African population when data is available? This is one example, and these are other examples. When data are available, you see that these are still being excluded in studies. So there's need for us to put Africa on the map. There's an initiative called the Global Biobank, a great initiative putting together different biobank across the world. And again, if you look at the middle, the African map, you don't see any African biobank be represented. But recently, in the last 1 year, we put Africa on the map. But you see Africa on the map just like one dot in the middle there. So that is the Ugandan genome resource, which I lead. So I think we need for more African data sets to be represented. Everybody here is very familiar with the story of PCSK9 inhibitors. So what I want to emphasize on this particular slide is that we know that this particular drug, which is helping to lower bad cholesterol, is made possible because some African ancestral individuals were included in the study. So if those people were not included in that study, it is possible that we will not have this drug that is helping to lower bad cholesterol. and also helping to prevent heart attack. So this is very, very important that we include whole population in study. Here's another example of a paper that was published just a few months ago. There was a variant that we found in a gene called CHDL1, CHD1L. So this variant is found in people of African ancestry that helps to reduce HIV load. And this might be important for a drug or medication for HIV. It's very important that we need to remember that there are very, very specific variants that are found only in African ancestry individuals. So you may know about ApoL1 gene. So ApoL1 gene can be, if you inherit two ApoL1 mutation, it means that you might mean that you have much more higher risk of developing kidney disease. In Africa, kidney disease is about 3 times more prevalent than other population. And there'll be some trial targeting this ApoL1 gene. So, which means that when drug is available, this will be doing some wonders for people that carry this particular variant. So here's the paper I mentioned. So we published a roadmap to increase diversity in genomic study. And the roadmap are very clear. So there's need for stakeholders. People have to be willing to, whether the researcher or the community, there has to be willingness for improving representation in genomics. There's also need for infrastructure to be built in the local settings, also strategic funding, capacity building, as well as a global consortium. I want to talk about this briefly, each of those points very briefly. So the first one is stakeholders way. You cannot overemphasize the need for community engagement in the community. So we started the Ugandan Genome Resource, which is part of the general population cohort in Uganda. So this cohort has been in existence since 1989. We go back to the same community almost every year. We administer the questionnaire and get sample from the individual. So we have built a lot of trust with the community. So in 2011, we started genetic epidemiology of NCDs. So what is helping the Uganda Genome Resource to be flourishing is because we are doing an amazing community engagement with the community. You have to, first of all, have consent with the community, with the stakeholders, with the leaders. We have what is called the Community Advisory Board, and this is a board that people on that board are the leaders in the community. You have the pastors, you have the imams, you have the community leaders, cultural leaders that are leading that community. So they give guidelines on kind of study that needs to be done. So community engagement is not a consultation. You don't just do consultation or just announce that we're going to be doing a study here. So it's much more than that. So it's key to genomic study in indigenous population. So that's about the stakeholders. Next one is we are leveraging local resources, the infrastructure in our unit at the MRC Uganda. We build a biobank where we store our sample. We have loads of serums, plasma, blood that have been stored for many years. And we recontact, we go back to those studies. We always try to get a broad consent that allow us to retest those samples that have been stored. So we also have a unit where we do the testing. Recently, we've been doing a lot of kidney function testing. We also have what we call the Uganda Medical Informatics Center. That's like a high-performance computing where we store the data and we analyze the data. So these are resources that are helping us to for the study to go on in low income setting. So I mentioned strategic funding. This is very important to improve representation. You might be familiar with H3 Africa. I think this was a very strategic funding. And this has been in existence for 10 years. You see amazing people that have been trained. I was one of the first people that were trained in H3 Africa in 2013 for my postdoc. You see also a few other people that after being trained with H3 Africa, so they're now taking a leading role. So many people have been trained, so samples have been collected. This is very strategic to improve representation. I think that we need more of those strategic funding for where we have the data being underrepresented. So recently, you might be hearing about the Genome Center for Excellence, GENCO. This is a partnership that is just being built to accelerate genomic science in Africa. So very important is capacity building. And this must be people must be trained in a very strategic way. So it's not to train people to do bioinformatics and analysis. Analysis is great, but some people must be trained to lead. Because if we have so many training going on in a low income setting and they don't have the capacity to lead, it's just will be a lot of waste of time. So in my group at the MRC Uganda, so my group is called the African Functional Genomic Group, which I lead. So we have a few people that we are training to lead in the future. So one of them is focusing on comorbidity, looking at how sickle cell disease is associated with kidney disease. One person, Alan Kalunji, is focusing on psychiatric genomics. Currently, we're going to be recruiting 10,000 people in the Uganda in GPC, and that will be led by this person because he's been trained to lead. We have a project on cardiometabolic genomics led by Okwashi Rebekun. He's been trained to lead. And we have Malawi Genome Resource, which we recently genotyped 7,000 people. So we have a postdoc that we based in Malawi that is helping to do analysis for this and also being trained to lead. So we are training some to lead because it's very important to increase representation. So we are also collaborating a lot. We collaborate locally in the region with different organizations, including East Africa, and also with like MVP, the Million Veteran Program. I've mentioned the Global Biobank. We do a lot of collaboration. We are doing very strategic collaboration where there is a mutual benefit for both us and also the collaborator. So we are also engaged in the public-private partnership. I think this is one way to go to improve representation. The funding agency are not able to fund everything. So a few years ago, in 2019, 2020, we partnered with a company in Nigeria to collect sample, 100,000 samples. That's very amazing. For me, I really feel this is a great initiative that we did. So we had a consortium that is called the NCD-GHS, partnering with this organization, and we have collected 100,000 samples that are currently biobank in Nigeria. So I think that African scientists must stop waiting for the government money that will never come because, like we've been talking a few days ago, many governments in Africa they don't see value in research, and we need to look just beyond that and look at the private partnership initiative. So in 2019, we published the largest ever genomic study, and that was just a study of only 7,000 people from Uganda, and we added a few other samples in Africa, making 14,000. And that was the largest ever in Africa. So that shows where we are in terms of genomics in Africa. So what you will see, we had 2,000 of those samples that were whole genome sequence. What you will see is that we had 9.5 million novel variants from only 2,000 samples. So here we did GWAS on 34 different cardiometabolic traits, and we also assessed their irritability. What I want to emphasize here, we find that height is less genetically determined in Uganda compared to European population. So like the narrow sense irritability for height in Uganda was 49% compared to estimate of 80% in European population. That is much more different. And again, in contrast to that, we found that irritability for low cholesterol was much more higher in Uganda, about 54%, compared to about 20 to 40% in the European population. So this paper was published this month, where before this paper, there was a big paper on GWAS of lipid traits in 1.6 million people. So you would think that most of the novel variants would have been found. So we did this paper focusing on only African population and identify additional 18 novel loci against lipid traits. So here in this paper, we did a genetic risk score where we show that if you are very familiar with genetic risk score, you will see what you see on this plot is directly like the opposite of what you will see. You will always see like a lowest transferability to African population. What we show here is that if you derive the PRS from a similar population, you see the PRS is doing very well in African population. So again, I mentioned that within Africa, there's a lot of diversity within Africa. So what we show here is that the transferability of PRS varies a lot within African population. So this plot you can see here is the Zulu population of South Africa, and this is Uganda population. So this is PRS for LDA, and you see this one achieving R square of 7.81, and compared to this that is not achieving the rate of PRS. So this was published also last year in Nature Medicine. So there's a growing number of African genome resources that are capturing genetic diversity across Africa. So this needs to be taken note of. I think that there's a great value for discovery, for genetic prediction that can generalize more broadly across global population. So for us to be able to achieve accurate genetic risk prediction and transferability across all population, there's need for large-scale African data that are necessary for PRS. I think that we might be doing PRS wrongly because what everybody is doing is trying to derive PRS in the European population and test for transferability in other population. So I think that maybe we should be doing it the other way around. We should build capacity in Africa, have large-scale data in Africa, derive PRS in Africa, which has more diversity, and test it in other populations. I think that's the way to do it. So in conclusion, Africa has the greatest genetic diversity, and as such, genomic data and resources are key for precision medicine. So despite many efforts, UK Biobank, all of us, American, Australian genome, Canadian genomes, so you see that representation of non-European ancestry group in genetic research still remain very, very low, and this affects diverse global population. I've shown you today that from relatively small size African genome resource, it shows great value for novel gene discovery and as well for genetic risk prediction. It is important that to benefit from everything we'll be talking about, it is important that we do genomic study in our population. It is to the benefit of all population if genomic study is diversified to include Africans and also other underrepresented population. So thank you very much for listening, and I'd like to acknowledge my group member who have done most of all the work I've mentioned today. Thank you.
Thank you for that great talk. I would like to introduce our next speaker, Dr. Claudia Gonzaga-Jauregui, who works in Mendelian genomics and rare diseases. She is currently at the Laboratory for Human Genome Research at the National Autonomous University in Mexico. So, Dr. Gonzaga-Jauregui, stage is yours.
Thank you very much, and thank you for the opportunity to talk to you in this very important session. And some of the themes that I'll talk about will be repeated with the previous speakers, of course, but hopefully that will make them more relevant, that you're hearing this from many people. So I can have my slides, please? Oh, okay. Okay, so I'll be talking to you today about the challenges and opportunities of implementing genomic medicine in Latin America. And so as Gabriela mentioned, so my work has focused over the last 13 years or so, mostly on Mendelian genomics and rare diseases. And so I think one major point is that rare diseases, Mendelian diseases, are some of the best examples of genomic medicine implementation that we have. So in the case of Latin America, so we know that rare diseases are defined based on their low prevalence in the general population, so they affect a small number of individuals. In the case of Latin America and the Caribbean, so we're talking about 33 countries in the region. There's no consistent definition of what a rare disease is in the Latin American region. So different countries have different definitions. So you can see here, Argentina, Chile, Mexico, Panama, and Uruguay have definitions similar to the European definition of about 1 in 2,000, so 5 in 10,000 people. Brazil has 65 in 100,000 people. Colombia, 2 in 10,000 people. So it's very variable. Also, different countries recognize a different number of conditions. So this makes it variable, the estimation of prevalence of different rare diseases across the region. As we know, these conditions are individually rare, but very common as a group, and they affect somewhere between 6 to 8% of the world population, so about 350 million people around the world. In the case of Latin America, we estimate that there are about 50 million people living with a rare disease. For Mexico, we estimate 10 million, but again, all of these are estimates based on this prevalence because most countries won't have registries. We don't really know how many patients living with rare diseases and which rare diseases we see in these countries. Also, as mentioned before, so in Latin America, we also have indigenous groups. So we have about 50 million people, indigenous people living in Latin America. And at this prevalence, so we estimate that there are about 3 to 4 million indigenous people living with a rare disease. Of course, there is a correlation between being indigenous and being underserved medically in Latin America. So this is also a very vulnerable group that has less access to healthcare services and prompt diagnosis. As we all know here, 80% of these conditions are genetic, so we know the molecular cause for about 6,700 of these disorders, and very few of them have a treatment available. Again, I don't need to mention to this audience the impact that genomics has had in the last decade to study rare diseases and Mendelian conditions. So in orange here, you can see the number of new disease gene associations that we had prior to 2010, which is when we started implementation of genomic sequencing for rare diseases. And in blue, you can see there the huge contribution that genomic sequencing has made to the study of genetic diseases, especially sporadic conditions or conditions that weren't occurring in these large pedigrees that were the source of these very successful initial genetic studies through linkage and that. So a lot of the conditions caused by de novo mutations have been defined now because of trio analysis through genomic sequencing. So we tried to summarize some of the progress that we have had and the impact of genomics on rare diseases in this book that we published in 2021. In the countries, within the countries. This also translates into low testing demands due to the limited access that patients and clinicians have to these type of technologies within the country. The few patients that can get access to these, generally these samples are sent out of the country. We are losing all of that data. They are sent to the US, to Europe to get tested, but none of that data comes back. Also, there's a lack of awareness from primary care physicians or specialists about the benefits, the advantages and disadvantages, and when to order a molecular test or what a genomic sequencing test will provide for the patient. There are few specialized laboratories and of course trained professionals that can do this type of testing within the countries. That also means there's little technical support because the lack of demand within the region. So most of the sequencing companies will send you a technician to fix your sequencer in a month, right? So for clinical laboratory, that is a loss of that testing time that they could do. So again, it's very challenging for molecular laboratories in Latin America to really invest in these technologies when they have these problems. There's also poor awareness and support for molecular diagnosis from policymakers. So we have had some policymakers telling us that, again, this is space science. This is something that's happening in the US, in Europe, but this is not something that's happening in Latin America. And there's consequently limiting testing coverage for by national healthcare systems, by insurance in these countries, because there is no proof of the applicability and the cost effectiveness of these approaches in the region. So we need to demonstrate this cost effectiveness and this value. And as was mentioned before, right, it's not just the cost, but also the impact in families, in patients, in lifelong care and management of the disease, but within the healthcare systems, within the economies of Latin American countries. So this is a bit of a different graphic from what has been shown in the previous two talks, but the message is the same. We have a problem of diversity and representation in genomics. This obviously has implications for public and precision health. So as it was mentioned before, so for Native American individuals, for African individuals, there's lack of representation, but this is for Latin Americans. So 0.33% of the samples in genomic studies are from Latin American individuals. So this increases disparities in access and the implementation of the benefits of genomic discoveries in underrepresented populations. The previous speaker talked about the lack of transferability of association markers of PRS application to other populations. In the case of Latin American individuals, we have a big spread. So individuals that have more European ancestry will have better performance of PRS versus individuals with more African or indigenous ancestry will have a much reduced applicability of PRS scores. So that's why we need to characterize our own populations, as was mentioned also previously, because we need to do these type of studies in our own populations. There's also a lack of specificity on the interpretation of genomic variants for rare diseases and medically actionable variants. So examples have also been mentioned before about variants that are considered pathogenic, but they might not be really pathogenic. Just there isn't enough sampling for those for individuals from those ancestries in the databases that we have. So we need to increase this diversity in genomic studies, but we need to do that in ethical, respectful, and collaborative, inclusive ways that include both the populations and the researchers doing genomics in the countries. Again, this map has also been shown, and here, again, we see the lack of representation of Africa, as mentioned before, but again, also for Latin America. So this so-called global South, as you can see here, is very underrepresented in genomics. So the importance of community engagement, again, cannot be understated. It's not just about getting the data, sequencing these samples. We need to get that data back to these populations, to these countries, so that we can do that community engagement and apply those findings to these populations. So it's not just about the Nature paper being published and showing the results, it's about what is the impact in these populations. And again, I won't go much into the WHO report, but I was very happy to contribute to the discussions in the roundtables for this report and the importance of achieving genomic equity for global health. So in the work that we're doing in Mexico, so when I went back after 12 years in the US, So we started this Mexican Network for Rare Diseases, which is a collaborative network of clinicians, researchers, patient organizations focusing on access to genomic technologies for patients with rare diseases in Mexico. So we launched the Rare and Undiagnosed Diseases Genomic Sequencing Program in January of 2022. And we are a research institution within the National University of Mexico. So we get the referrals from medical geneticists that evaluate these patients that are part of the REMEXER network. We do genomic sequencing in collaboration with Baylor College of Medicine and more recently with the Tec de Monterrey in Mexico to try again to build that capacity within the country to sequence within the country and don't have that data leave the country. So we do all the analysis, the bioinformatic analysis, and any follow-up that it's needed, including functional testing at the International Laboratory for Human Genome Research. And we also have a return of results program planned for the parents. So we're mostly doing trios sequencing. So we're planning to return results for actionable variation in the parents of these children as well. So we recruited our first patients in January of 2022, and so far we have 30% of the patients sequenced with a known diagnosis due to variants in known genes. However, I do need to mention that even though these are known genes, most of the variants that we are identifying in these patients are novel. So that also means we need to do more functional tests and that, but again, emphasizing the point that we are still discovering novel pathogenic variation when we are looking at these populations. And also we have 40% of the cases with novel candidate genes. We have currently 50 families that are waiting in the fridge because we don't have any more funding at the moment to continue sequencing. So hopefully next year we can do more sequencing. But so far those are the results, again, emphasizing both the need and also the impact of doing this type of projects in Mexico and in Latin America. We also launched the Rare Disease Patient Registry in February of 2022. And we also do outreach and educational activities. So one of the activities is the annual International Rare Disease Day Symposium. And also we produce materials and other activities, but everything we're doing is in Spanish because, again, this lack of information and educational materials in other languages different from English. And especially in Latin America, there are many primary care physicians and specialists that do not speak English. So we're really trying to reach that population as well as patients. And so that's a bit of what we're doing in Mexico. But again, this situation is similar in Latin America. So back in 2020, a group of people, we started to meet by Zoom and discuss about the needs and challenges of rare diseases patients in Latin America. So we started working on this initiative, the Enfermedades Raras en el Caribe y América Latina, ERCAL initiative, with the vision to sum and consolidate some of the efforts that are happening in Latin America across the board. So it's not just on the genomic side, but also regulation, raising awareness and advocating for better legislation that also covers access to treatment, to integrative care for these patients, promote and establish early diagnosis programs and registries across the country, the region, sorry, and promote cooperation among stakeholders in the Latin American region. So we've been working on these. We have very active working groups working on all of these different aspects of the needs of patients living with rare diseases in Latin America. And also one of the things that came up in the conversations of the needs that we need to address is also reaching these indigenous populations, because there is still a lot of taboo and and misinformation for indigenous communities when a patient has a genetic disease. So they are ashamed, they hide these people. So just starting to educate more and bring some of this information. So here you can see a snapshot of the website in Quechua, which is an indigenous language that's spoken in Peru, Ecuador, and Colombia, and some other countries in Latin America. But the idea is to start producing some of these informational materials about rare diseases to reach also people that not necessarily speak Spanish or Portuguese. So again, we have the technology. We know how to analyze exomes and genomes, but we do need to make sure that this technology is applied equitably around the world so that every patient with a suspected genetic disorder can have access to an accurate and prompt genetic diagnosis, no matter where they were born, where they live, or what their socioeconomic status is. So, of course, we are not doing this by ourselves. We are establishing collaborations and working with, again, regional initiatives like ERGAL, but also international organizations like G2MC, WHO, UDNI, and others to achieve diagnosis, improve research, increase education and training on genomic medicine for Latin America. And so I'll just point here. So again, these are my students in Mexico, and you can see they are very young, most of them. So they are from the Genomic Sciences undergraduate program. So for 20 years in Mexico, we have had the Genomic Sciences undergraduate program, which has been really successful. But we've been exporting genomicists to the world. So we do have a problem with brain drain and not offering opportunities for some of these students to come back to Mexico and do the research or the implementation that we need in the region, in the country. So we have a problem there for repatriating and giving those job opportunities to these students. So with that, I'll just acknowledge every other of our collaborators and funding. And so some of the patients that we've been able to sequence were also part of the rare diseases pilot project of G2MC that Alan Schuldiner talked about yesterday. And so we are very thankful for the support as well from G2MC. And I'll be happy to answer questions during the panel. Thank you.
Thank you, Claudia. So I'd like to introduce the last speaker for this excellent equity and global access session, Lyndon Mitnaul, who is an executive director in the Regeneron Genetics Center at Regeneron Pharmaceuticals in the US. Thank you, Lyndon.
Great. Thanks to the organizers for giving me this opportunity to speak today. I don't know who that is in that photo, so I'll just keep moving along. But today I'm glad and very happy to tell you about a new initiative we're starting. We really believe this is a unique public-private partnership that's focused on addressing health disparities in our Black population. And I must say that this initiative is we believe, a catalytic movement, but also a start. This is not the end, but the beginning, and it could be a model for a lot of different types of initiatives like this. So we really hope this is a model, a start to having these discussions for many different populations. So this initiative is called Together for Change, and I came together with a colleague at Meharry Medical College, Anil Shankar. Anil was supposed to be on the stage with me today, having this discussion with you. But unfortunately, due to convocation at Meharry Medical College this week, he was unable to travel, but sends his regards. So what are we trying to change with this initiative? And I think, we said it many times in this forum already. If you're not affecting the patient or the population of people, we're really not making change. So change here is really changing healthcare for people of African ancestry through an international genomics and equity initiative. This is a genetic study, but it's not only a genetic study, and I like to focus mostly on the equity part of this versus the genomics part, because I do believe if we build equity in our communities, in our education, it will, through genomics, it will come to improve and advance healthcare. So what we're really trying to address is two structural systemic problems we have, and that is in education. STEM jobs are, about 9% taken by African adults. And when you look at life and physical sciences, this number even goes down to 5%. And it's been shown that, the prospect of increasing diversity in the workforce is closely tied to the educational system. The second problem, and we've heard it many times this morning, is the lack of diversity in genomics. So, and I should update this slide from Segun's presentation to 1.1% of genetic information being studied today coming from people of African ancestry. And, this creates a healthcare gap in preventative medicines and looking at new discoveries as well. And we heard many examples of that this morning. So our focus in this initiative is on the many communities where we have people of African ancestry across the world. And we're focusing on two specific groups as a start. We have to start somewhere. And that is in the US with our historically Black colleges and universities, as well as different institutions across the continent of Africa. And we really want to support diversity, equity, inclusion in these understudied, underrepresented populations. We have a lot of similar issues as in Africa, even within developed countries like the US. I'm a product of a historically Black college, and I can tell you that, we don't have resources. We don't have a lot of, focus on support for STEM education in these institutions as well. So we feel that, coming together, we can advance genomics research and medicine through these strategic partnerships. But these partnerships are going to take all of the organizations that are represented in this room and outside of this room, like government, communities, academia, biopharma, technology, you name it. It's going to take all of us to bring our skill sets, bring what we have within our organizations and the passion of the people that make up these organizations to solve this problem. So that's really what we tried to do here. And, there's some precedents to this because we heard about the UK Biobank today, and I put this slide in on purpose last night just to highlight that we've done this before as an industry. Biopharma industry led by Regeneron. We went out and sought these companies listed here to pool resources and sequence the UK Biobank. This was the whole exome sequencing consortia. And, this group of companies are competitors against each other, but we had a common purpose and passion to provide this resource to everyone. We met for many months and over the last 4 years of forming this consortia. And I think, again, that was a model to spark the whole genome UK Biobank consortia, which a different set of companies got together and sequenced the whole genome for this data set. We get together, we talk, we look for other opportunities to work together. And, we spun off even another project where we took 52,000 participants within the UK Biobank and pooled again funds and did a proteomic study, a O-link proteomic study, where again we looked at 3,000 proteins over 50,000 participants, and again this data is available through the UK Biobank. So we believe this is an example of pre-competitive merging of resources among these different organizations to help solve a problem. And that's what we're trying to do here with Together for Change. A group of pharma companies led by Regeneron again got together with one of our historically Black medical schools, Meharry Medical College in Nashville, Tennessee, started having discussions some 3 years ago. So this is not a new idea. This is an idea that we've worked on for many, many years, got a lot of feedback from folks, and are ready to launch this very, very soon. Meharry has formed a new 501c3 nonprofit organization called the Diaspora Human Genomics Institute. This is independent of Meharry, has no employees at the moment. We're looking for folks. And, the DHGI will be the governing organization for this initiative. That is, it will be managing all of the activities, be providing all of the grant funding from this initiative to the different schools. And one of the first things they did with the DHGI was to form an ethics committee so that everything that we do from start of this initiative is seen through an ethical lens. We really believe this is a unique partnership because we're bringing together all of these organizations, again, institutes in Africa, the Biopharma Group, all of our 107 HBCUs in the US, as well as other US institutions to come together for 10 years. So we understand that change like this takes time, and this is a 10-year commitment for these organizations. And again, the goal here is to solve this international education and healthcare challenge that affects many of our Black communities. So our overall goal is to really close the gap on the historical inequities in healthcare, education, and training through accelerating education pathways, building new STEM pathways, building more diversity in genomics research and researchers, and improving genomic tools for people in our African ancestry communities. And our specific goals are, fivefold here. We're going to empower, and we heard a lot about this already, empower our communities on health and medical research. Especially in the US, we have a lot of mistrust, distrust of research in our Black communities. So we're going to drive these discussions and really listen to our communities and hearing what they need and want in terms of health and lifestyle and research. 2, we're going to build new STEM programs and provide students early exposure to STEM careers and inspire them. We heard that also about the lack of inspiration of seeing people that look like you, come from communities like you, to be a scientist or to work in a STEM field. 3rd, we're going to expand the genetic counseling workforce. Of the 107 HBCUs we have in the United States, none of them have a genetic counseling training program. And of the 4 historically Black medical schools in the US, none of them have a medical genetics fellowship program. So we're going to start the first joint HBCU program on genetic counseling, as well as the first medical genetics fellowship program. 4th, we're going to increase the number of African researchers, and specifically those in genetics. This will be through a lot of planned, training and mentorship programs that we'll be having in this initiative that's focused on our HBCUs as well as institutes in Africa. And last, we're going to diversify genomics research and participation by creating the largest ever African ancestry-specific genotype-phenotype database. We aim to, you know, get volunteers up to 500,000 participants, both in the US and in Africa for this study. And then not only create this database, but provide this database exclusively through the DHGI to our African researchers as well as researchers in our HBCUs. These schools could share the data with whomever they would like to share the data with, but by providing the data exclusively to them, it allows them the control and the, you know, the ability to collaborate with larger institutions to build capacity at their schools. I wanted to add this slide in because I thought, you know, it is something we're dealing with in the US. And as I mentioned, there is a lot of mistrust, distrust of research in general. But now when you layer on genomics research, you know, it's even more of an eyebrow raiser. So we looked a few years ago, you know, did a quick artificial intelligence machine learning exercise online and looked at, you know, what conversations were being had regarding genomic testing and genetic research. And this is a summary of 650,000 digital discussions on that topic, with about 50,000 of those discussions coming from people that self-identify as Black Americans. If you look on the left in green, you can see that about 20% of the conversations online were positive about genetic research and genetic testing and genomic research. And this is down 1.5-fold versus the overall average. If you look on the right in the red, you see about 30% of the conversations are negative about genomics research and genetic testing. And this is up 1.7-fold versus the average. A lot of this, you know, negativity was around, you know, how's it done? There was a lot of confusion and misinformation, a lot of distrust of healthcare providers and costs. Now, and rightly so, I can understand that. As I mentioned, you know, the lack of genetic counselors, the lack of community engagement, the lack of education in this population about genetics research. Now, there's an opportunity here, though, and I see this in the middle here, where about 50% of the discussions were neutral. So 50% of Black Americans went online to understand what genetics research was and how this work will affect their health. So we really believe that this initiative could help move this, you know, red as well as the neutral folks to the green. So what we're trying to do in this initiative is really to set up an ecosystem of collaboration where we bring together our HBCUs, our institutions in Africa together to research together, to work together, again, along with some of our US institutions that will be a part of this initiative. In addition, as I mentioned, BioPharma is bringing in funding, as well as other skill sets and opportunities to work together and look at some of the things that even we talked about or heard about today, like pharmacogenomics. And, you know, I really think community engagement, and we heard a lot about that already, is the key, and it's going to take all of the groups together to have those conversations and explain the importance of participation and how this does affect our health and how we can do it in an ethical and fair way. There's a lot of opportunities by working together in this ecosystem to have collaborative projects, have multi-institution funding opportunities, mentorship and training, postdoctoral trainings, internships, co-ops, sabbaticals. We can do all of that, share the knowledge, share the professional development and career opportunities for academia, industry, government, you name it. So this is the goal, and all of this, again, will be managed and organized, coordinated through the Diaspora Human Genomics Institute. So it will take all of us, though, and I was asked to say what G2MC could do and how you can participate. We have different organizations in the room here. I heard talks this whole week about, the passion to bring genomics medicine to everyone. Let's see how this initiative could help the efforts that you're working on, as well as how you and your organization can help Together for Change. So with that, you are a special group because this is not even public yet. We've executed this agreement this summer and have been working on our public announcement, which is happening October 18th at Meharry in Nashville. Welcome everyone to come and be a part of this and follow up, more importantly, to make all of this happen after that announcement. So thank you.
So thanks to the speakers, and we invite you to come up to the stage. I want to start this session really by congratulating you on all your the amazing work and how you really contribute to decrease these relevant gaps. And I know that we've been running a little bit late due to multifactorial reasons, but since conversations are really so important, Ludi gave us permission to start the coffee break a little bit late and have this conversation. So I already see hands in the audience. So Amira, if you can kindly use the microphone, please, and there are microphones here for you.
Thanks so much. This is excellent. One of the best sessions for this conference. And my question to Segun, I see that amazing work you're doing. And I mean, we all heard about Africa and all the needs and all the shortage of resources and all of these things. But what you presented to us is like something coming from different planets, it's not from Africa. And it is, to me, it is very impressive. And I was just wondering, if this is the case, why not Uganda be the center of excellence for the genomic research for all Africa? You guys take the lead, train everybody, do the required, don't look for other countries, and do the job for yourself, between yourselves. Seriously, I mean, I don't know, I don't see why not. If you have been publishing in Nature Genetics for all of these things, I'm amazed, and 2022, 2023 is very short time. Tick, all of these, like, very nice. Congratulations, of course. But this is means something big. You can take the leads. I think this is what you should do, guys. Thank you.
Thank you very much. And I have to laugh for maybe 2 minutes to be able to answer your question. Okay, so it takes a long time to be where we are today. And one of the things that have helped is strategic funding. So what I presented today, there was no way I would have done that 10 years ago. So we had NIH and Wellcome Trust funded History Africa for 10 years up to last year. And they trained, too many people were trained for either postdoc, for PhD, for MSc. We had a lot of data coming out. So that one initiative has brought a lot of change to Africa. So there's no way anybody will have shown you that slide maybe 10 years ago. And you can see most of the publications I've shown today, there were people that were published only this year, last year, year before. When I was doing my postdoc, which I started in 2013, for 3-4 years, I published no paper. And there were many people also that published no paper because we were training. So what I would like to say is that there's need for more of such initiative. And I think it will not be appropriate to keep on going back to NIH and Wellcome Trust So NIH is American money, it's not African money. So Wellcome Trust is money coming from the UK. So I think that Africa needs to think about how we can get our funding from our own government. So many governments in Africa, they are not responsible. They don't care about that. So that's why a private-public initiative is key. And I show an example of one of those that we did in Nigeria. And now currently we start talking with Regeneron about public-private initiative. I think that's the way to go. But there's so many things to learn. Yeah, we need to learn on how to negotiate. I want to negotiate rightly with Lyndon, and we don't know. Normally scientists don't have that kind of skills, because we have never done this before. But this is a stage where we need to be clear, we need to be transparent, we need to know how to go about that. So I think that's what we have now, where we need to look beyond NIH and Wellcome Trust and all the funding agencies and start talking to biopharma and see how we can do things for something that will be mutually beneficial to both us and to them. Thank you very much for the question.
Rich, and I can't see who's on the back.
Rich Haspel from Boston. That was a great session. My question is a bit US-centric, so it's more for Dr. Dale and Dr. Mitnaul. There's no question there have been terrible healthcare disparities based on race, in quote-unquote race, in the United States, because there are artificial categories that have changed over decades. But my question is, the National Academies just came out a report about population descriptors in genetics research. And there's a big problem in medicine. There's like a classic story where an 8-year-old black girl had lung problems her whole life. No one could diagnose it. And then a radiologist who didn't know what color skin they were said, who's the kid with cystic fibrosis? Because we're taught in medical school in the United States, there's this typological thinking about genetics and race when race isn't a genetic thing. Okay, traits do not follow boundaries based on skin color and things. And so my question is, on one hand, we want to get away from these healthcare disparities and increase, participation of underrepresented groups. But on the other hand, there's this danger when you start grouping people by these race categories that you're going to lead into typological thinking and thinking certain genes are only seen in certain people and, and when the vast majority there is, they don't follow. It's about population genetics and although certain things are more common in certain. So the bottom line is, it seems you have these two things competing, or not competing, but one can lead to the other. And I was just wondering for both of you, how do you navigate that? Get inclusion, avoid healthcare disparity, but not think, oh, the color of skin defines you. Hope that makes some sense.
I would say make anti-racist curriculum a part of education for medical students. And because getting rid of race in the picture is actually a erasure of our people and really just diminishes who we are. And it shouldn't be erased from the idea of like who they are as a person, because it's a part of where they are and in their background. And yeah, just be anti-racist and stop being racist.
Well, I guess the issue is, though, when you have groups that are focused on including people based on that, which is important, it's very difficult to distinguish between the two for people who don't have the education, or who aren't being taught that. And I can tell you, medical schools are still working on it. So you have groups which are important to bring that in, that both of you are doing. But teaching the medical students isn't going to do it, right? How do you get it out to the public to make sure that there isn't this conflation between the two, between healthcare disparities and race as a biological genetic construct?
Yeah, I think we go to the data, the science and the graphs that we've seen shows the reason why we need to put focus on these ancestral groups. Let's just show the data and explain the data and explain the opportunities. I mean, we heard about the Dallas Heart study with PCSK9, and when you include a people of African ancestry, you make discoveries that help everyone. So it's not focusing only on one, race. It's bridging the gap in healthcare for everyone. And it just so happens that we have to focus on some of these groups that have been underrepresented.
So Matt Brown, Genomics England. Since the mid-2000s, one of the things which has really driven the advance of at least common disease genetics has been the widespread availability of data and the resulting reuse of data over and over and over again, enabling researchers around the world to access data sets that they themselves couldn't create. And this has been to a huge advantage of the global population. Each of the speakers who presented today have talked about the need to actually build local resources and local capabilities and capabilities in their own communities in genomics. And at least three of you that I heard talked about restricting data access to people within specific defined communities rather than opening it up to widespread use, which I would put to you also would have the disadvantageous effect of reducing the number of eyes looking at the data and therefore the potential benefit to your communities as well. And I understand that there's a conflicting need here, but I'm wondering if I could hear from the speakers about what they think about the solution to this conundrum is, because I think just restricting it to within your own community is going to be problematic. Just for example, UK Biobank, 95% of current users of UK Biobank are not from the United Kingdom, and that has brought the global community a huge benefit.
Yeah, I can start, and I think others can chime in, but I don't think that we are saying necessarily to restrict access. Especially because many of these projects, if we want them to be large scale as we need them, have to be done in collaboration, whether that's a private-public partnership or with funding from NIH or Wellcome Trust or others. So there will be other people that we need the support to do these large-scale projects. So I don't think we're talking about restricting access, but I think, again, and we've talked about this over the conference, I think there is definitely a need to have equitable access and equitable collaborations. So it's not just like helicopter research, come take the samples and be sequenced at the Wellcome Trust or at Broad or somewhere else or at Regeneron. Is the investigators in the countries, in the regions, in Africa and Latin America should have access, should have in some ways some perhaps some period of exclusive access, because we cannot compete with the infrastructure that Regeneron has or that Oxford has to analyze this. So we do need some ways to leverage to level the play field so that we can play at the same level at the international level. But I think, and I think we all agree that access to genomic data is a good thing for everyone, for the community.
Yeah, if I can just add very quickly that Claudia is absolutely right. And Together for Change, the data is not going to be restricted. It's giving the organizations like Claudia mentioned the control and of choosing who they want to collaborate with. I mean, right now you have Meharry Medical College right next to Vanderbilt University. And Meharry would go to Vanderbilt and ask them to collaborate on genomics research, teach their faculty, students how to do analysis. And they probably won't do it because, why do something extra? And what do you have to bring? So we're trying to provide a resource to some of these HBCUs so that then the PWIs, the predominantly white institutions, will work with them. So it's not restricting it to them. It's putting the control into the HBCUs and institutions in Africa so they can choose who they want to work with and bring funding into those schools. Because as you know, you can publish on UK Biobank data and you get grant funding, right? And so if you can analyze the data very quickly, as Claudia mentioned, you're going to be the one who get those publications. So, we're just trying to provide an equal, equitable playing field for those.
Just to add to that, example from the Uganda Genome Resource, if you go to EGA, you will see Uganda Genome Resource deposited. So, and we had so many people, most people that have asked, that have requested access for our data are mostly from the US and the UK. But we didn't give that, we didn't just make it available after sequencing. We had to publish first. Because like both of them said, we cannot compete if you sequence our data and make it available today, you are going to publish all the papers because we don't have the facilities to compete with you. So the model in History Africa is you put an embargo on data for 12 months until we do all the slow motion and publish our paper. And when we do that, we make it available. It doesn't mean that within that 12 months, we're not collaborating. So we collaborate with people. And we understand the need to make data available. And having said that, I know that even in Africa, there are some people that still restrict their data, and we don't blame them for that. There are some indigenous population that have previously expressed some harms, and they don't want their data to be shared. Of course, we need to go ahead and build more trust with those indigenous population. But generally, we are open to share our data and collaborate with people globally.
Claudia, do you have something
Yeah,
to
I
add?
just think there needs to be control over the data that's being produced from my people. And I think there's just a lack of understanding of indigenous peoples and tribal nations. And if research is going to be done on it, there needs to be a collaboration to make sure that there's no biases.
Jürgen?
So I want to be positive and encouraging. And so I see people who are from developing countries who are young and they're complaining that the government doesn't care. There is no funding. So being older and being white, I know actually what it takes. And what it takes is young people like you who rise through the ranks, who advise government, maybe even become a minister someday so you can change the system. No, don't laugh. You may someday, or one of your friends will, but at least as you rise through academia, you become advisors to the government, you sit on commissions, you tell them what to do, or at least advise them what to do, and eventually there will be the money because people like you will change the system.
That's very encouraging. Maybe one day I will change my career being a scientist. I'll be a politician.
Be a good one. Any more questions? Yes, Claudia.
Thank you for the presentations. My question is going to Claudia. When you started working on rare diseases, your strategy was driven by prevalence or by actionability. That means you were focusing or targeting diseases that were prevalent just to know about the genetic background in Mexico, or you were looking for diseases where there is a treatment like metabolic diseases, and then you can improve the patient management in that case. Or maybe another strategy where, and how do you evaluate your strategy after these years of experience? Thank you.
I mean, the research program for rare diseases, rare and diagnosed diseases in Mexico, it's very broad. It's open to all diseases. We've focused a little bit on neurodevelopmental disorders recently, mostly because that's the funding that we have. So we got a grant for neurodevelopmental diseases. But the idea is to, the objective is to enable access because most of the patients in Mexico don't have access to molecular testing. So the only test that it's offered in the public system is a karyotype, which won't diagnose most of the patients, and is too costly to pay out of pocket. So there are very few people. So in the registry of 144 people, only 8 have had exome or genome sequencing all out of pocket. and it's extremely expensive. And again, everything is sent out. So the idea is just to enable access to and then from there we can start looking at prevalences and frequencies of variants in that. We have access now to a large data set for Mexican population where we're starting to look like frequencies for carrier variants for certain metabolic diseases and that, but for the sequencing part, it's just open enrollment.
Well, thank you. This has been a great session. Thanks to our speakers and to the audience for participation. I think this is a topic that's really at the heart of G2MC, like we heard on the first day of genomics for everyone being our core mission. So this is really an example of that.